Hello and welcome to our project about pulmonary tuberculosis. This project was created by Marilyn, Andy, Grace, and Victoria. We hope by the end of our project you learn, understand, and can explain a little bit more about pulmonary tuberculosis than you did when you walked in. We hope you enjoy our project.
Tuberculosis is a highly contagious disease, and it's caused by Mycobacterium tuberculosis. What makes the bacteria special is that the cell wall contains fatty molecules called malic acids, creating a thick, waxy coat. And with that waxy coat, or protective coat, this allows them to hide inside the macrophage, also from the immune system. How can it be spread? Well, when an infected individual and susceptible hosts are together, the infected individual coughs or sneeze or yell, they release droplets that contain Mycobacterium tuberculosis. And when the susceptible hosts inhale, they are inhaling the tiny droplets that contains the bacteria. So then, the bacteria travel down our respiratory system from trachea through bronchus, bronchiole, and mainly resides inside the alveoli. When the bacilli arrives at the alveoli, it triggers an immune response, and the first cell to recognize the bacterium is the macrophages. In a normal process, macrophages' job is to engulf foreign substance and break them down. However, since the bacteria has that waxy protective coat, this inhibits acidification of phagolysosome. Macrophage still engulfs the bacteria, and it won't undergo phagocytosis because it cannot break down the bacteria. So then, the bacteria inside the macrophage reproduces itself. Then, the macrophage then undergoes necrosis, releasing and spreading the bacteria. The release of the bacteria triggered the cell mediated immune response. Immune cells such as B cell, T cell, more macrophage gather at the alveoli. Since there's an accumulation of immune cells at the alveoli, this forms a granuloma just over a few weeks. Granuloma is a collection of fibroblasts and lymphocytes which surrounds dendritic cells and infected macrophage. The center of the granuloma undergoes a morphological pattern called caseous necrosis without disrupting the dormant of the bacteria. As shown in the picture, the cheese-like material is caseous necrosis. It's a type of cell death, which dead cells disintegrate but is not completely hydrolyzed. Accumulation of immune cells in the blank forms a granuloma over the next few weeks. A. Bronchioles. B. Alveoli. C. Left lobe of the lung. D. Right lobe of the lung. E. Left primary bronchus. Answer is alveoli, because the bacteria is able to accumulate and form a granuloma. There is two stages of TB. One is latent TB and two is active TB. People who has latent TB is not contagious and can live a normal lives. This is due because the bacteria that resides inside the granuloma prevents bacteria from reproducing, and it is mostly under controlled. The bacteria may remain in our system for decades, but can be reactivated if it's not treated. If the bacteria is reactivated, the granuloma gets destroyed. The bacilli that resides inside the granuloma is then spread into neighboring alveoli, into our bloodstream, and other parts of the body, affecting and damaging tissues. This is called active TB or TB disease. Hosts are symptomatic and they are contagious, and getting treated as early as possible is important before it becomes a problem. I'll pass it on to Victoria with assessment points.
Assessment points are really important in diagnosing tuberculosis. There's many different kinds of questions that are important to ask the patient when they present at the hospital or the clinic. One really important question to ask our patient is if they have a history of HIV. Patients who have been infected with HIV are more at risk for complications regarding tuberculosis. It's also really important to get information on where a patient has been. Some countries have a higher chance of a patient acquiring tuberculosis. It's also important to ask them if they know anybody with tuberculosis. Tuberculosis is transmitted with air droplets, so it's easier for someone to contract TB than, say, other infections may be. It's also important to find out what other medical history is important to your patient, such as if they're immunocompromised, do they have any other diseases? These are really key assessment points for our patient. Other things to figure out are the demographics of our patients. What's their job? Are they a healthcare worker? Are they maybe more at risk from working in a lab? These are all things to ask the patient and also to figure out about their ethnic and racial group. Sometimes that can give us a bit more information with what we're dealing with. The age of our patient and where the patient is from are also really key points. For example, if you have a patient who recently moved to the US in the past 5 years, the country that they are from may have more cases of tuberculosis. These are all questions that are important for us to be asking our patient. After acquiring a comprehensive medical history from our patient and looking at their demographics, we need to actually look at our patient now. Patients with tuberculosis are going to have a productive cough. It's important for us to see what color is the sputum. Different colors of sputum will point us to a different direction with different kinds of diseases. For our purposes here, we are looking for a bloody rust-colored sputum. This will help confirm our diagnosis of tuberculosis. The next thing we want to do is learn more about that cough. How long have you been having that cough? When did that cough start? Asking these kinds of questions helps us understand exactly what is going on with our patient. A patient just having bloody sputum is not enough to point us in the right direction. We want the history of that cough. After asking questions about the cough, we want to examine their lung function. We want to see exactly how the lungs are working. A patient with tuberculosis is going to have compromised lung functions. It's important for us to make sure to look at that as well as the cough itself and what the cough is producing. After asking about their cough and looking at the sputum, it's important for us to ask questions to our patient concerning their weight. Tuberculosis patients tend to lose weight. It's important for us to ask, have you lost any weight in the past few months, few weeks? Ask them if they've noticed any changes with their sleep. Have they had a harder time going to bed at night? Are they waking up in the nighttime sweating? Are they waking up coughing? These are really important questions to ask. And finally, it's important for us to get their temperature. A patient with tuberculosis is going to have a fever. We need to make sure that we're checking their fever, their sleep, and their cough, and their sputum. These are all key assessment points for our patient. A 24-year-old man complains of a non-productive cough, sore throat, and body aches. The nurse believes the patient has tuberculosis. Do you agree with this assessment? Why or why not? We do not believe this to be tuberculosis because there aren't really any obvious signs. A tuberculosis patient will have a productive cough. We'll see that sputum. It's important for us to see that when diagnosing tuberculosis. And it's important to know that although a patient could have body aches and maybe they could have a sore throat, those are not key signs of tuberculosis. And honestly, that's really not enough to point somebody into the direction of a tuberculosis diagnosis. The more important things for us to look for are a fever, sweating, weight loss, and rust-colored sputum. Of course, you could also do some imaging and see a granuloma in that imaging as well. But when it comes to just looking at the patient, that would really not be enough to diagnose tuberculosis. So for us, the answer is no. This graphic shows a really good, comprehensive, bullet point idea of what you'll see in a patient with tuberculosis. You see that night sweat. You see the patient having a fever. You know they're fatigued. They have experienced weight loss. They have a productive cough with bloody sputum. These are all things that you're going to see in a patient with tuberculosis. And again, this is just drilling in the idea. How does that patient get tuberculosis? because they inhaled air infected with Mycobacterium tuberculosis. That's how they got this infection. Luckily, we have tools in our hands to be able to test for tuberculosis. We are able to do a PPD test. This is a relatively easy procedure. It's a subcutaneous injection, and it will allow us to see a reading in about 2 to 3 days to figure out if the patient has tuberculosis.
The diagnostic findings for tuberculosis, most often we know of the PPD skin test, which is a purified protein and derivative skin test. 2 office visits are normally required. First one is to administer the PPD tuberculosin into the outer layer of the skin. And the second visit would normally be 48 hours to 72 hours after for the second office visit to observe if there is any reaction to the area where the PPD tuberculosin was injected into. Then there is also the fluorochrome acid fast bacilli sputum test. TB bacterium normally resist decolorization chemicals after being stained, and 3 samples are obtained to confirm positive diagnosis. And when you do have a positive skin test, that normally doesn't necessarily say that you have active TB. So a chest X-ray would be ordered to identify if you have active TB or latent TB. And the chest X-ray would assess images of the lungs. So here on this slide, we have images of what we would observe after administering the PPD skin test. Different diameter and size would be 5 millimeters, 10 millimeter, or 15. This on the bottom shows the process of acid fast stain. An image of a chest X-ray of what it would look like for a person that has active tuberculosis. Left-hand side shows a normal lungs, and on the right side shows the lesions and cavities.
When examining a chest X-ray, what would the medical professional be looking for in the imaging to help confirm a tuberculosis diagnosis? Yes, perfect. That's exactly what we're looking for. We're looking for lesions. A patient with tuberculosis is going to form granulomas. Remember, because Mycobacterium tuberculosis is able to evade our immunity system, granulomas are able to form. These lesions should be visible on the imaging.
So with treatment of tuberculosis, the methods will depend on the stage that tuberculosis is in. We use antibiotics to kill Mycobacterium tuberculosis, and the most common method of treatment is orally. The drugs that we use are rifampin, isoniazid, pyrazinamide, and ethambutol. These medications can be combined in treatment or used alone depending on the severity. With the mechanisms of drugs, isoniazid inhibits synthesis of mycolic acids, which is an essential component of bacterial cell wall. Next is rifampin. Rifampin inhibits bacterial DNA-dependent RNA polymerase that leads to suppression of RNA synthesis. And ethambutol infuses into the mycobacterium cells and inhibits the arabinosyl transferases, which is an enzyme tuberculosis uses to form cell walls. And lastly, pyrazinamide is metabolized in tuberculosis into pyrazinoic acid, which disrupts membrane potential and interferes with energy production. So, latent tuberculosis, the most common treatment is isoniazid therapy for 6 to 9 months daily. You can also utilize combination therapy or other methods for shorter and better completion rates, like 4 months of just daily rifampin or 3 months of daily isoniazid plus rifampin. Next, moving on to active tuberculosis. The usual treatment is about 6 to 9 months, and that's split into two stages. The first is the intensive stage, where it's 2 months of daily intake of isoniazid, rifampin, ethambutol, and pyrazinamide. This is followed by a continuation phase for 4 to 7 months of just isoniazid and rifampin. In rare cases where tuberculosis becomes drug resistance, we have to include fluoroquinolones in the treatment as well. Fluoroquinolones inhibits activity of DNA gyrase and topoisomerase, which is an essential enzyme for bacterial DNA replication. So we have to use combination therapy, including fluoroquinolones, for 20 to 30 months, and most of the times this gets really costly.
A patient was recently diagnosed with drug-resistant tuberculosis and asked his doctor how his disease is treated. The best response would be IV fluids to flush out Mycobacterium tuberculosis from the bloodstream, use of multi-antibiotics for maximum of 4 months, use of multi-antibiotics for 20 to 30 months, combination therapy with use of fluoroquinolones for a maximum of 12 months, combination therapy with use of fluoroquinolones for 20 to 30 months. That's the perfect answer. Combination therapy with use of fluoroquinolones for 20 to 30 months is crucial for the patient having the best recovery. In some cases, patients do have drug-resistant TB, unfortunately. It's really important to get a drug that can stop enzymes that are crucial for bacterial DNA replication to happen. So we want to inhibit the activity by gyrase and topoisomerase. This will allow our patient an opportunity to heal.
For patient education, we would like to make sure that patient understands what tuberculosis is. We can explain to them again what tuberculosis is caused by a bacterium called Mycobacterium tuberculosis. The bacteria usually attacks the lungs. It is airborne and carried through infectious droplets that are produced by an infected individual's cough or sneeze, or even simply talking. Not everyone infected with TB becomes sick. Therefore, two TB-related conditions exist. There is the latent TB infection and TB disease, both which can be treated. Without treatment of latent TB infection, it could progress to TB disease. If not treated properly, TB disease can be fatal. Infected patients and supportive families should be educated on how and when the patient will need to take their medication if prescribed. So therefore, the patient must be disciplined about taking their medication. We will need to make sure that the patient will complete the course of drug therapy, because one of the main reasons for the development of drug-resistant TB strains is the failure of patients to actually finish and complete the prescribed course of medication treatment. It can take up to 9 months of drug therapy. For patients with the drug-resistant strains of TB, may take up to 18 months of treatment.
A 25-year-old college student was recently abroad and came into contact with a person diagnosed with tuberculosis. A few months later, the student finds that they are feeling lethargic, losing weight, sweating in the night, and having a productive cough with bloody sputum. They are then shortly diagnosed with pulmonary tuberculosis. What would be the best response to the college student in regards to managing this sickness? A. You will need an intramuscular injection every 2 weeks for the next 8 months to treat latent tuberculosis. This can be done at home or in the clinic. The intramuscular injection consists of the drug fluoroquinolones. B. Broad-spectrum antivirals will destroy the bacteria Mycobacterium tuberculosis. They require 8 to 18 months of treatment depending on the severity of your TB. It is crucial to stay on top of your medication regimen or else you risk the infection not being resolved and reactivating. This can be dangerous for long-term health and could even cause death. D. This is a bacterial infection. Use of interferon medications are necessary to kill both latent and active tuberculosis. E. Once tuberculosis has spread to the lungs, the main concern is palliative care. At this point, the bacteria has caused granulomas to form. This cannot be resolved by the use of antivirals or antibacterials. Great job being able to identify that it is very important for tuberculosis patients to have a good regimen when it comes to their medication. It is crucial for patients to take their sickness seriously. When patients do not take care of tuberculosis, we see that drug-resistant strains begin to form. We want to avoid this for their sake and for the sake of others. It is really important to treat with whatever medication is necessary for the stage your tuberculosis is in. As we saw earlier, there are a couple different stages of tuberculosis, and the care can change. Some of the options do show options that can treat tuberculosis, but the key thing to realize here is that while those other options are somewhat correct, they're not fully correct. This is a bacterial infection. You will not be using antivirals. Therefore, you would not be using interferons. Although you can use the fluoroquinolones, that is really only for more of drug-resistant tuberculosis. The main thing we want you to understand here is that a good regimen is key for our patient having the best outcome possible. We want to thank you for taking your time to learn a little bit more about pulmonary tuberculosis with us today. On this slide, you'll see the references we used to be able to bring you this presentation today. We hope that you enjoyed the project and that you have a good rest of your day. Thank you for your time.